Mad in America is a critical look at the treatment of the mentally ill in the United States. Author Robert Whitaker talks about the business and science of treating and caring for the mentally ill over the last 300 years. He spoke recently in Cambridge, Massachusetts, for just under 2 hours.
In Mad in America, Bad Science, Bad Medicine, and the Enduring Mistreatment of the Mentally Ill, medical journalist Robert Whitaker reveals an astounding truth. Schizophrenics in the United States fare worse than those in poor countries, and over the past 25 years, outcomes for people with schizophrenia in this country have worsened. Indeed, Whitaker argues, modern treatments for severely mentally ill put factors such as management and cost ahead of the comforts and needs of the patients. Tracing over 3 centuries of, quote, cures for madness, Whitaker shows how medical therapies and drugs have been used to silence patients and dull their minds, deepening their suffering and impairing their hope of recovering. Based on exhaustive research culled from old patient medical records, historical accounts, and government documents, this haunting book raises important questions about our obligations to the mad, what it means to be insane, and what we value most about the human mind. Publishers Weekly called Mad in America rich, and Kirkus Review said it offers a, quote, scorching indictment of the status quo. It sure packs a wallop. Robert Whitaker's articles on the mentally ill and the drug industry have won several awards, including the George Polk Award for Medical Writing and the National Association of Science Writers Award for Best Magazine Article. He was a finalist for the Pulitzer Prize for a Boston Globe series on harmful research involving the mentally ill that he co-wrote in 1998, a series that led him to write this book. Please join me in welcoming Robert Whitaker.
First, thank you all for coming out on a night like this. I very much appreciate it. I thought that rather than read from the book at all, I'd basically just talk about some of the themes that are raised by Mad in America, by this history. And also and the question that this history raises for all of us as a society. And I also want to leave some time for questions afterwards because this subject tends to be a very controversial one and it provokes rather strong emotions. As Nancy mentioned, I became interested in this subject about 4 years ago while reporting on abuses of psychiatric patients in research. And while I was doing that story, I kept coming upon outcome studies that I found at that time quite mind-boggling. And they were of 2 sorts. One was a study by Harvard Medical School researchers in 1994, which found that outcomes for schizophrenia patients in the U.S. had declined over the past 20 years and were now no better than they were in 1900 when the therapy of the day was to wrap the insane in wet sheets, which is rather mind-boggling when you think, of course, we have these sort of modern care, modern drugs, etc. It just didn't fit with everything that I had read about schizophrenia in the past. The other were 2 studies by the World Health Organization. In the 1970s and 1980s, the World Health Organization twice did comparative studies of outcomes in developed countries versus developing countries. And what they found each time was that outcomes for schizophrenia patients in the developed countries, this is US and 7 other well-off countries, were markedly worse than in the poor countries such as India, Nigeria, and Colombia. And what they found in those poor countries was this spectrum of outcomes, which you'll find very surprising. In the poor countries, they found about 40% of patients who suffered a schizophrenic break basically recovered in a period of, say, 1 to 2 years, and were basically unimpaired at the end of that period. Another 25% of patients might have had a 2nd or 3rd psychotic episode, but each time they remitted to the point that they recovered their full, what was called pre-morbid status, which means they were functioning as well as they were before they ever became ill. And then about a 1/3 became chronically ill. Whereas in the US and other rich countries, the overwhelming majority became chronically ill, and you did not see the same pattern of recovery. Now, the World Health Organization did not identify a reason for this variable in outcomes. They looked at various factors like social care, family integration, that sort of thing, but they really couldn't identify any factor that could explain this amazing difference in outcomes. However, they did look at, they did make a mention of the difference in medical care. And what they found in the poor countries is that only 1 in 6 patients was regularly maintained on antipsychotic medications. Whereas in the rich countries, in the US and other countries, that of course is the cornerstone of care, continual medication. Now that does not prove anything in and of itself, that the medication is the variable that is the problem. However, it is suggestive that there may be something going on over the long term that the medications are causing a problem over the long term. I will say this too, the World Health Organization concluded after it went back on the second study that it said living in a developed country was, quote, a strong predictor that a person with schizophrenia would never recover, which is a rather amazing finding. So my thought was, with this book, was basically to explore this failure and to do so through the prism of history, to basically trace the history of medical treatments since the colonial days and see if there's any sort of story that evolved that would explain this modern-day failure. Now, the roots of mad medicine in English cultures goes back to the 1600s and the 1700s when English doctors set up commercial madhouses where they would take, people suffering from delusion, psychosis, and people that, frankly, families often just wanted to get rid of. And they started publishing medical texts with saying that they had ways to cure or treat the insane. And the competition, in fact, was so fierce at this time, by the end of the 1700s, many of these medical writers, these doctors, were saying that we'll cure the insane or you get your money back. It was very much a commercial enterprise. Now, at this time, in these medical texts, they basically conceived of the insane, this was the age of reason, by virtue of having lost their reason, as having descended to the level of brutes, to an animal-like status. And so the medical therapies that they developed were basically in response to that conception of the mentally ill. So, for example, you can read in the medical texts where they advised occasionally whipping the mentally ill in order to instill fear and obedience. They also would bleed them very aggressively, purge them very aggressively, and this, of course, would also weaken the mentally ill and make them more manageable. Another form of therapy that was popular in the late 1700s was the spinning chair. They would rotate the mentally ill very violently. They would become nauseous and sick. And again, you could see how this would indeed weaken patients, make them less likely to be disruptive, that sort of thing. So in a sense, you could say that they worked. Finally, one of the more bizarre therapies of the day in the late 1700s was a sort of drowning therapy. And what the advice was that you would hold the patient underwater until they lost consciousness, and then you would bring them back up and hopefully revive them. And the thought was that maybe a new personality would emerge at that time. So these were the teachings that were employed at the first hospital in America, in Pennsylvania Hospital, in the late 1700s, when the physician that oversaw the care there was named Benjamin Rush. He was the preeminent physician of the day. And of course, he basically employed these teachings because they were seen as the medical wisdom of the times. Rush also invented his own novel therapy called the tranquilizer chair. It was a wooden contraption that basically held the person very firmly. He couldn't move a muscle, and he would keep the patient in there for an extended period of time. And Rush boasted that his wooden chair could in fact assist in curing madness. And I'll just read very quickly of how he wrote about this device of his. It binds and confines every part of the body. By keeping the trunk erect, it lessens the impetus of blood toward the brain. By preventing the muscles from acting, it prevents the force and frequency of the pulse. And by the position of the head and feet favors the easy application of cold water or ice to the former and warm water to the latter. Its effects have been truly delightful to me. It acts as a sedative to the tongue and temper as well as to the blood vessels. In 24, 12, 6, and in some cases in 4 hours, the most refractory patients have been composed. I call it a tranquilizer. Now, Rush was a good man, empathetic towards his patients, and he believed this chair was in fact a biological remedy for mental illness or for madness. And here's why he believed it was so. He believed that madness was caused by too much blood rushing to the brain, and therefore the chair, by confining all parts of the body, by the arms and the legs, would prevent blood from going to the brain and therefore cause the blood to pool in the feet. and that by applying ice to the head, he was also cooling the brain as well. So he saw this was a way to basically ameliorate the problem of too much blood rushing to the brain. Now, we read of this therapy today, and of course we think, oh, it's cruel and absurd and ridiculous. Well, in a way, again, it did work. If you kept a patient in this chair for 24 hours, it did weaken them. They were afraid of the chair. And as one European doctor subsequently wrote, this invention, by the way, was exported to Europe, and it became quite popular there. Anyway, as one European doctor subsequently wrote, the chair would, quote, make the most stubborn and irascible patient gentle and submissive. Now, during the 1700s, the English public often wasn't so keen on these very aggressive therapies that were being peddled by the mad doctors, and often said, we need a reform of some sort. And the reform was led by the Quakers in the 1790s under the guidance of a man named William Tuke. And what the Quakers believed is this idea that the mentally ill were animals was wrong, and that what we needed to do, what they needed to do, was to consider them as brethren and treat them as such. So what they set up was basically a home-like shelter for the mentally ill, with the idea that if you provided them food and shelter and empathy, and basically held up a mirror to them that said to them, you have the capacity for behaving well, and capacity actually for getting control of your mind, that this sort of environment, this nurturing environment, could indeed assist nature, they would say, in helping the mentally ill get well. And I'll just read a brief bit from the shelter that they opened in 1796. The Quakers opened their small home in 1796. It was a simple place with gardens and walks where the ill could get their fill of fresh air. They fed patients 4 times daily and regularly provided snacks that included biscuits along with a glass of wine or porter. They held tea parties at which the patients were encouraged to dress up. During the day, patients were kept busy with a variety of tasks, sewing, gardening, and other domestic activities, and given opportunities to read, write, and play games like chess. Poetry was seen as particularly therapeutic. The Quakers borrowed their medical philosophy from the ancient wisdom of Aeschylus. Soft speech is to distempered wrath medicinal. The therapeutics of the English mad doctors, wrote Samuel Tuke, William's grandson, in 1813, were those at which humanity should shudder. The one medical remedy regularly employed at the York retreat was a warm bath, which was to last from 20 minutes to an hour. If it be true, Samuel Tuke reasoned, that oppression make a wise man mad, is it to be supposed that stripes meaning blows, and insults and injuries for which the receiver knows no cause are calculated to make a madman wise? Or would they not exasperate his disease and excite his resentment? May we not hence most clearly perceive why furious mania is almost a stranger in the retreat, why all patients wear clothes and are generally induced to adopt orderly habits? Now, the first such moral treatment asylum in the U.S. was opened by Philadelphia Quakers in 1817, and soon others appeared in other cities along the eastern seaboard. Here in Boston, a moral treatment asylum opened in 1821, and this came to be known as McLean's. Now, this form of small asylum care, which was known as moral treatment, meaning tending to the emotions, was basically the standard of care for about 35 years in the United States. And historians who've gone back and looked at the results have found that it did indeed produce fairly good results. They found that more than 50% of patients, the newly insane, who entered these asylums each year, would be discharged within the course of 12 months. And the best long-term study that was ever done, involving more than 1,000 patients, found that more than 50% of those patients never relapsed the rest of their lives. So we see in moral treatment, basically in this distant history, some evidence that a nurturing environment and many of the things that we all need to remain well and healthy, comfort, friendship, shelter, food, etc., can indeed help people, restore people to good health. The downfall of moral treatment, ironically enough, came as the result, or somewhat as the result, of the activities of an activist named Dorothea Dix. She had suffered a breakdown of her own early in her life, and she had gone to England, where she had basically been nurtured to health back to health by some Quakers and been exposed to their philosophies. And so she came back to the United States in the 1840s and wanted to make it her life's work to expand this form of care so it was available to the population at large in the United States. In the earlier days, the small asylums largely catered to a fairly well-to-do clientele. And in response to her pleas, in fact, the United States, the states responded with a great generosity. There was a wave of asylum building, so much so that the number of mental hospitals in the country increased from 18 in 1840 to 139 in 1880. The problem was, as these asylums were built, two things happened. One, patients with all sorts of disorders were basically dumped into the asylums. People with syphilis, alcoholics, the senile elderly were all put in these asylums. They also grew greatly in size. The idea with moral treatment was you needed to have a very small place, no more than 250 patients, where there could be a direct interaction with the doctor. And as a result, you ended up with these bleak warehouses housing 1,000 or more patients. And of course, people with syphilis and the senile elderly no longer got well. And so moral treatment came to be seen as a failed treatment by the end of the 1800s. Now, the next prominent turn in our country's care of the mentally ill took hold in the first decades of the 20th century. And this really, I think, is one of the real dark periods of our history, one that we as a country, I think, have never really gone back to revisit, and I think we actually should. This was when the eugenics movement took hold in the U.S. Now, we usually think of eugenics as a movement we associate it with Nazi Germany, but actually eugenics was a movement first nurtured here in the U.S., and was first here in this country that state policies that were enacted based on eugenic beliefs. Now, eugenics arose out of Darwinian understanding of evolution, that species could evolve over time. And if you believe that, then the thought was the human race, or at least as this is what the eugenicists argued, could improve itself in this way. It could encourage those with good genes to reproduce, and it would discourage those with bad genes from reproducing. The idea would be you would actually prevent those with bad genes from reproducing. Now, this, of course, raises all sorts of problems about who has good genes and who has bad genes, and of course, the eugenicists basically came from the ruling class, and so the movement in the U.S. was very much led by graduates and frankly, academics at such schools as Harvard, Yale, Princeton. It really was the ruling old Yankee elite that pushed this agenda in the United States. Well, what did that mean for the mentally ill? Well, the mentally ill, of course, were seen as having the worst genes of all, and they were targeted as a group that, in essence, needed to be done something about their genes that they were passing on. Now, the first thing that happened is eugenic scientists started publishing articles claiming that insanity was indeed a genetic disorder, so much so that by around 1915, you could read in medical texts that insanity was passed along, it was a single gene disorder, and passed along much like eye color was. And once that became the accepted wisdom of the day, it became the foundation for various policies designed to keep the mentally ill from reproducing. The first was we passed laws, and this, I think every state passed this law, prohibiting the insane from marrying. The second thing that we did is we started, the idea was that the mentally ill, in fact, needed to be segregated into asylums. And so instead of putting the mentally ill into hospitals where the hope was they would get some care that would help them heal, and then they would be discharged and go back into the community, the goal really became to keep them there until they passed reproductive age. And indeed, you start seeing from 1900 on through really the 1940s, the discharge rates go way, way down, and you started seeing people spending their whole lives in the asylums. Well, that was a social policy. That wasn't a reflection of the illness itself. And finally, what happened, of course, was states started passing laws authorizing the forced sterilization of the mentally ill. The first such law was passed in 1907. 20 years later, the U.S. Supreme Court ratified such state laws as constitutional. And by the end of 1950, in that first 50-year period, there were around 50,000 Americans so forcibly sterilized, with about half of those mentally ill patients. The other group that was really targeted for forced sterilization was the mentally retarded, as they were called at the time. Now, it's interesting to note two things. In 1933, Hitler came to power, and one of the first things his government did was pass a forced sterilization bill. And at that time, the Nazi government said, we are going to sterilize 375,000 mentally ill patients in our country over the next few years. Well, it's telling in terms of the tenor of the times in the U.S. that was fairly widely applauded in the U.S. as a progressive health measure. So, for example, the New York Times ran an editorial supporting the Nazi bill. The New England Journal of Medicine also ran an editorial praising it as a progressive humanitarian health measure. And it just shows how basically societal beliefs can really affect what our beliefs in terms of how the mentally ill should be treated. Finally, it's important to note, during this time, the 1920s, 1930s, the rhetoric that was directed by eugenicists, and the eugenics movement really had the support of the majority of Americans, was incredibly harsh towards the mentally ill. You would hear eugenicists write and talk about the mentally ill as social wastage, as poisonous slime, as cancers on the body politic. Leading scientists talked about how they were a species of humanity that needed to be exterminated. It is really it is chilling stuff to read. And in fact, there was some discussion about whether or not the mentally ill should be killed. In 1921, I believe it was, Connecticut briefly debated the possibility of a law for the mercy killing of the mentally ill, which was reported upon in the New York Times as if this was a possible rational thing to consider. And in fact, in 1935, a Nobel Prize-winning scientist at Rockefeller Institute for Medical Research in New York City, Alexis Carrel, wrote about this very explicitly. He said that the insane, and I quote, should be humanely and economically disposed of in small euthanasic institutions supplied with proper gases. This was published, by the way, by a mainstream publisher, so it wasn't considered that outrageous. Now, it was during this eugenics era, during the late 1930s, that 4 therapies arrived in asylum medicine that were of a rather peculiar sort. These were insulin coma therapy, metrazole convulsive therapy, electroshock, and prefrontal lobotomy. Now, in the media, these were all heralded as wonderful breakthrough treatments for mental illness, that there were now cures for mental illness. However, once you got away from that public facade and listened to what the psychiatrists and the neurologists were talking about, it becomes quite clear that they worked in a very specific way. And in fact, what the psychiatrists at the time openly acknowledged is that they worked by inflicting a sort of brain trauma on the patient. And in fact, they were sometimes dubbed, collectively, brain-damaging therapeutics. Now, for instance, insulin coma therapy worked by depriving the brain of sugar, and that's why the person went into the coma. They found that this sometimes caused brain hemorrhages, and in some instances it did indeed lead to death. Metrazole was a very powerful poison. About a minute after it was injected, the person would go into a convulsion so severe that at times they would break bones. Many suffered spinal fractures. They shattered their teeth. Muscles sometimes even pulled away from bones. It was a horrible, awful treatment. Electroshock was initially developed as a method to induce seizures in a more controlled way than with metrazole. So it was really just seen as a mechanism for doing that. Interestingly, also, when they studied electroshock therapy in the 1940s, they said it produced a trauma that was very akin to closed head injury, i.e. concussion. Now, what doctors found with this is that after one such treatment, patients would emerge a bit dazed, lethargic, and therefore quieter and easier to control in the asylums. But however, once they began to recover from this trauma, of course, their agitated behavior and delusions might return. So the form of care that they then settled on was that you needed to run patients through this form of treatment, whether it be insulin coma treatment or metrazole convulsive therapy or electroshock numerous times, 30 times, 40 times, 50 times, with the idea that this trauma would basically take hold and finally produce a more lasting change. And the idea was that after 30, 40, 50 times, the person would become less self-conscious, less Frankly, they talked about a reduction in intelligence. In fact, I'll read a quote from a well-known psychiatrist at that time, Dr. Abraham Myerson, as to why they saw this as affecting a cure. Quote, "I think it may be true that these people have, for the time being, at any rate, more intelligence than they can handle, and that the reduction of intelligence is an important factor in the curative process. I say this without cynicism. The fact is that some of the very best cures that one gets are in those individuals whom one reduces almost to amentia." Amentia means like simple-mindedness. Now, lobotomy was seen, and properly so, as the most precise way to basically affect this change in being. Now, when this surgery began to become popularized in the 1940s, there was a lot of research being done on frontal lobe function. And what scientists at that time knew quite well and understood quite well is that the frontal lobes were the part of the brain that most distinguished us from primates and other animals. Primates, of course, have frontal lobes, but ours are much more pronounced. And they realized that frontal lobes were sort of the seat of self-consciousness. It's the part of the brain that allows us to worry about ourselves, fret about our futures, care about ourselves. And so this surgery, in essence, was disconnecting, because what you did in frontal lobotomy was basically disconnect the frontal lobes from the rest of the brain. And so the surgery, in essence, was attacking the very part of us that we think makes us most human. And here's how Walter Freeman, who was the biggest promoter of lobotomy in the U.S., described the change wrought by lobotomy. After the lobotomized person, unable to form a mental picture of the self, would no longer worry about past or future. And here's what he wrote. "He is freed from anxiety and from feelings of inferiority. He loses interest in himself, both as to his body and as to his relationship and as to his relation with his environment. No longer caring whether his heart beats or his stomach churns, or whether his remarks embarrass his associates. His interests turn outward, and obsessive thinking is abolished. There is something childlike in the cheerful and unself-conscious behavior of the operated patient." So that was the change that was seen as good at this time. In 1943, an investigator reviewed all the lobotomy operations done to date. There had been more than 600 at that time. And he concluded that doctors had reported that the surgery had improved 84% of patients who underwent it, and that fewer than 1% had in any way been harmed by the surgery. After that report appeared, lobotomy was seen as a very much accepted, medically proven therapy. The number of lobotomies exploded, and the media treated it as a miracle sort of surgery. Surgeons were said to be wizards that could neatly pluck mental illness from the brain. In 1949, the inventor of this surgery, a Portuguese neurologist by the name of Egas Muniz, actually won the Nobel Prize for lobotomy. So it's something that is rather remarkable today. Now, the modern era of treatments for mental illness really can be traced back to the introduction of Thorazine in 1954. Thorazine was brought along as a drug initially for use in anesthesia, and what it could do is it could numb the nervous system, the central nervous system, without causing people to lose consciousness, and this was seen as important for surgery. It was introduced into asylum psychiatry after physicians noticed that it also made people apathetic, less alert, and slow in their movements. The first psychiatrists, in fact, praised it for producing a change similar to that seen in lobotomy. They called it a pharmacological lobotomy. Now, you have to realize at that time that was seen as a good thing, and understandably so. I mean, in 1949, surgical lobotomy won the Nobel Prize in Medicine, so if you had a pill that could now affect a change in being that's what was somewhat similar, it only made sense that that would be seen as a better way to do it. Today, we know how Thorazine and other drugs of this type, which are called standard neuroleptics, by the way, they work, exactly what they do to the brain. These drugs all block dopamine receptors in the brain. They block a particular type of dopamine receptor known as the D2 receptor. Now, dopamine, as most of you probably know, is a very key chemical in the brain. It's in terms of how the brain communicates with itself. And these drugs basically block 70 to 90% of the D2 receptors. Now, what does that do to a person? What change does it affect? Well, it really affects a person in three pronounced ways. First, the basal ganglia is an area of the brain that very much relies on dopamine. There are three areas of the brain that very heavily rely on dopaminergic neurons. So obviously, we're going to see change in function related to those three areas of the brain. The first is the basal ganglia, which is responsible for the initiation of motor movement and the control of motor movement. Now, you get Parkinson's disease when you lose about 80% of the dopaminergic neurons in this area of the brain. So in other words, you're only functioning at about 20% of normal, and that's when you get the shaking symptoms. So of course, what happened when you block 70 to 90% of the dopamine receptors in this area of the brain with thorazine, you get some problems with motor movement. You get Parkinsonian symptoms. So in reality, it's not right to say that the Parkinsonian symptoms are a side effect of these drugs. They, in fact, are a direct effect of these drugs. It's a straight they do what Parkinson's disease does. The same sort of pathological deficiency in dopamine transmission. Now, the second area of the brain that really relies on dopaminergic neurons is the limbic system. The limbic system is an area of the brain where we basically respond emotionally to the world. It's how we feel the world. It's also important for mounting emotional responses to the world. So it relies on dopaminergic neurons as well. So you block this transmission, and patients often say, well, they feel sort of emotionally cut off from the world. They feel like zombies, and that's why, because you're blocking the limbic system from really its full activity. Now, the third part of the brain that relies on dopaminergic neurons is indeed the frontal lobes. For example, in animal experiments, if you turn down or basically shut down the dopaminergic neurons, they'll say it's the same thing as surgically removing the frontal lobes. So that's why you get these comparisons between a chemical lobotomy and a surgical lobotomy with standard neuroleptics, because again, you're creating sort of the same dimming of function in the frontal lobes. So that's what the drugs do, and that became somewhat clear. It's quite clear today, but it became very clear by, even in the late 50s that the drugs were dampening down dopamine transmission to a very severe degree. Now, in terms of judging the merits of these drugs, there's really a couple ways to look at it. The first is, how did patients feel about these drugs, that subjective response? Now, one of the things that I do think has been a horrible mistake over the past 50 years, particularly when standard neuroleptics were the drugs of choice, there wasn't a lot of listening to the patients and how they responded to these drugs. And, the subjective experience means a lot, and obviously that is critical. And now some patients at least seemed to respond okay to these drugs, said it made them feel more tranquil, more calm. But a more common response was that they described it as they very much resisted it. They found it painful to have their dopaminergic system shut down in this way. They felt separated from the world as if by a glass screen. They complained of feeling like zombies, and there was a biological reason for that. Now, their complaints, actually, they brought their complaints to the Senate in 1975 in a very interesting hearing. The Senate was holding the hearing because neuroleptics were being used in very many settings, in juvenile delinquent settings, with the mentally retarded. And the thought was, there was this overuse of the drugs. But it was the mentally ill who really stepped forward to describe what it was like to be on these drugs. And they talked about how, frankly, it produced the worst misery, how that left them feeling mummified and sort of not alive. And I want to just read real briefly a testimony from a woman who testified at that hearing named Janet Gotkin, because I think it's one of the most articulate descriptions of how many people felt on these drugs. I became alienated from myself, my thoughts, my life, a stranger in the normal world, a prisoner of drugs and psychiatric mystification, unable to survive anywhere but in a psychiatric hospital. The anxieties and fears I had lay encased in a thorazine cocoon, and my body, heavy as a bear's, lumbered and lurched as I tried to maneuver the curves of my outside world. My tongue was so fuzzy, so thick, I could barely speak. Always I needed water, and even with it, my loose tongue often could not shape the words. It was so hard to think, the effort was so great. More often than not, I would fall into a stupor of not caring, or I would go to sleep. In 8 years, I did not read an entire book, a newspaper, or see a whole movie. I could not focus my blurred eyes to read, and I always fell asleep at a film. People's voices came through filtered, strange. They could not penetrate my Thorazine fog, and I could not escape my drug prison. The drugs made me constipated as well as ravenously hungry. As a final misery, they caused me to gain weight. For 8 years, I took laxatives and suffered as I watched my body grow heavy and distorted. My hands shook so I could barely hold a pencil, and I was afflicted with what Dr. Sternfield lightly called dancing legs, a Parkinsonian side effect of these chemicals. For this, I took a drug called Coumadin, and if I missed a day or a dosage, my shoulder muscles would tighten into excruciatingly painful knots, and my legs would go on wildly out of control. These drugs are used not to heal or help, but to torture and control. It is that simple. Now, interestingly, drugs were condemned at the Senate hearing for use with the mentally retarded and for the elderly in nursing homes. However, the person who chaired that hearing, Birch Bai, said, however, we are not concerned about their use in the mentally ill when it's being used in the mentally ill after a proper diagnosis. So basically, the Senate carved out an exception saying that while other people might experience these drugs in a difficult fashion, the mentally ill, it was okay to use them with them. Shortly after that, the mentally ill did mount some court challenges, saying that they wanted the right to forego treatment. They somewhat won those challenges. It became sort of a due process issue that psychiatrists could still take patients to court and get a court order to allow forced treatment. It's interesting, the argument that was made in response to the patient's court challenges was that the mentally ill, being sick, didn't understand that they were sick and needed these drugs. And while there may be some truth that the people in the midst of a psychotic delusion aren't judging themselves well, again, that's a response that somewhat negates their own experience. And it is interesting at this time during the 1970s that the Soviet Union was using these same drugs on its dissidents, basically to break the will of its dissidents, and their dissidents were complaining quite loudly about how miserable these drugs made them feel. Now, that was really a subjective response to the drugs. The next question is, what does the research literature show? And remember, we started this talk about why were outcomes worse in the United States and other developed countries where these drugs were used continuously, as opposed to the poor countries of the world where only 1 in 6 patients were so kept on the medications. And the research literature is actually quite surprising. I mean, I was stunned as I began to trace this forward. The study that established the efficacy of neuroleptics was conducted by the NIMH, that's the National Institute of Mental Health, in the early 1960s. And in a 6-week study, they found that indeed, patients treated with the drugs, their psychotic symptoms abated more quickly than the symptoms in the placebo group. And in 1964, they made a big statement saying that these drugs are quite safe, and in fact, it looked like it affected a cure in about 50% of patients in a 6-week period. And even today, that is a study still often cited as really establishing the efficacy of the neuroleptics. But what happened when the NIMH went back a year later and looked at the fate of the patients at 1-year follow-ups? And what the NIMH found at that time was that the group never exposed to the drugs, the placebo group, had a lower rehospitalization rate than any of the drug-treated groups. There were actually 4 arms in the initial study. 3 groups received a neuroleptic, 1 group was a placebo group. The placebo group had a lower rehospitalization rate than any of the 3 drug-treated groups. So here you have the first sign of a bit of a paradox, that you have drugs that can indeed dim symptoms over the short term, but may be causing some sort of long-term chronicity in psychosis. Well, after that, in the next couple of years, there were several other studies with some other unsettling news. Researchers noted that it seemed like relapse while on medication was more severe than a placebo relapse. The symptomatology was worse than in those never exposed to the drugs. They also ran a drug withdrawal study in which they took everybody off the drugs, and they found, and they did 2 such studies, that relapse rate rose in direct correlation to the dosage that the patients were on. The higher the dosage they were on before withdrawal, the greater the incidence of relapse. Now, what all this suggested, what this began to suggest, was that the drugs were exacting some change in the brain that over time actually made people more biologically prone to psychosis than they would otherwise naturally be. Now, this in the 70s actually led to 3 very interesting studies funded by the NIMH, one of which was led by Lauren Mosher, who at the time was the head of schizophrenia studies at the NIMH. So he was basically at the top of prestige in the country for schizophrenia research. And in each of these trials, what they did is they randomized patients upon initial treatment into non-drug and drug treatment arms. Now, the non-drug treatment arms did get psychosocial care of some sort. They just didn't leave them untreated. And now in each of these studies, the non-drug treatment group, the group treated without drugs, actually had fared better over follow-up periods that ranged from 1 to 3 years. They had lower relapse rates, and they also had better sort of social outcomes as well. And what was really pretty remarkable, and I think as we go forward with the question and answer period, is in each instance, more than 50% of the patients treated without drugs, in fact, recovered and didn't relapse at all during the relapse periods, the follow-up periods that extended as long as 3 years. Now, by 1979, Canadian investigators had basically explained what was going on and why the drugs were making people more prone to psychosis over time, more biologically prone. And this is a little bit of a confusing story. It's one I don't think that's it's been really kept hidden from the American public, but I think it's sort of critical to really understanding why you see this long-term chronicity. If you remember, the drugs dampen down dopamine activity, and powerfully so. Well, in response, let me just back check, because how this unfolded is really interesting. Initially, the investigators understood that the drugs block dopamine activity, so they hypothesized, well, schizophrenia must be caused by too much dopamine activity, an overactivity of dopamine in the brain. And that's why you started hearing in the 70s, oh, these drugs are like insulin for diabetes. People with schizophrenia have too much dopamine activity in the brain, this dampens it down, and it's sort of normalizing brain chemistry. That became the hypothesis. So now but that was a hypothesis. Now they had to investigate to see whether that was true. Now the first thing they looked at was whether neurons in the brains of people with schizophrenia were putting out too much dopamine. And the way they checked that out was they looked in their blood and urine and the cerebrospinal fluid for metabolites of dopamine. These are the breakdown products, and to see if there were unusually high levels of the metabolites. And what they found is that prior to being medicated, there were no such higher levels of metabolites. Now, after medication, you do briefly get an increase in metabolites, and that's because in response to the dopamine, the drugs blocking dopamine, the brain actually tries to compensate and starts pumping out more dopamine. But that only lasts for a few weeks. The second thing they then looked at, they hypothesized, well, okay, if the neurons aren't putting out too much dopamine, maybe the problem is they have too many dopamine receptors, and that they therefore are hypersensitive or supersensitive to dopamine. And initially, it seemed like they had found indeed that. They looked at brains at autopsy, and they found that people with schizophrenia had maybe 50% more dopamine receptors than normal. And there were some exclamations, some pronouncements that the cause of schizophrenia apparently has been found. The problem was that if you read the original research, the researchers said, but we don't know if this is caused by the drugs or not. We need to look at unmedicated people with schizophrenia prior to medication, and we also need to do animal studies of this sort. Well, what they found is that indeed, prior to medication, there was no extra, they did not have an extra number of dopamine receptors. But what happened was, in response to medication, again, trying to compensate for this dampening down of dopamine, the brain, what the scientific term is, upregulated or increased its number of dopamine receptors. And so basically the drugs created the very pathology that was hypothesized to cause schizophrenia in the first place. I doubt if you've heard that very often in the popular literature. And this was basically understood by 1979, and Canadian investigators had publicized this, and they wrote, and they came forth with this conclusion, which is rather a stunning moment, I think, in the history of our care. Their names were Guy Chouinard and Barry Jones. They wrote, and I quote, neuroleptics can produce a dopamine supersensitivity that leads to psychotic symptoms. An implication is that the tendency towards psychotic relapse in a patient who has developed such a supersensitivity is determined by more than just the normal course of the illness. Now, the other thing that is thought to be caused by this increase in dopamine receptors is tardive dyskinesia. Tardive dyskinesia hits about 5% of patients on standard neuroleptics each year, and it's cumulative. So, for example, you'll see 5% of patients begin to suffer from it after 1 year, 10% after 2 years, 15% after 3 years. And what tardive dyskinesia is, it's a more permanent form of basically brain dysfunction, loss of motor control. You'll see the tongue sort of rhythmically moving in the mouth. You'll see other sort of muscle, lack of motor control of muscles. When they've also studied, it's also associated with some cognitive impairments. And the reason it's permanent is because even after the drugs are withdrawn, you often don't get a remission of these symptoms. So this was all quite clear by the 1970s. Now, since then, there has been virtually no exploration of non-drug alternatives in this country. However, a few European investigators have run such experiments, and each time they have reported good results. In Switzerland, for example, in 1992, they ran such an experiment, and they concluded that patients treated with no drugs or low drugs had significantly better results and better social outcomes. Sweden ran such a study in the 1990s as well. They found that about half of patients, first episode patients so treated, could do well without neuroleptics. And overall, the experimental group that was treated in this manner, and the manner was this: they would try to treat people without neuroleptics. If some people weren't doing well, then they would place them on neuroleptics, and that was the experimental group, versus a control group that was immediately put conventionally all on neuroleptics. And they found that this experimental group, treated in this sort of selective manner, had lower rates of hospitalization use and overall fared a little bit better. And finally, Finland in the year 2000 also conducted an experiment of this sort, and they found that 44% or 43% in fact did not need neuroleptics over a 2-year period, fared well. And that overall, this experimental group that was treated in this selective manner, some people, where they would try not to place people on neuroleptics right from the get-go, or otherwise use low dosage, that this experimental group generally did as well or better than the group treated in a conventional manner. The final piece in this puzzle was put in place by investigators at the University of Pennsylvania in 1998. They reported that MRI scans showed that MRI scan showed that after you placed people on these standard neuroleptics, you got an enlargement of the basal ganglia over an 18-month period, and that this enlargement of this area of the brain was indeed associated with a worsening of both positive and negative symptoms. Positive symptoms are the psychotic delusions, the hearing voices, that sort of thing. The negative symptoms are social withdrawal, lack of social integration, and what they found is that this enlargement, which indeed is visible on MRI scans over an 18-month period, indeed correlated with a worsening of symptoms. So we started this talk, why were outcomes worse in the US and other developed countries than in the poor countries of the world, and I think you can see that with these old drugs anyway, there's a fairly complete picture. You see, for example, the first long-term study, greater rates of hospitalization. We know the biological change caused by the drugs that make people more biologically prone to psychosis. We also know that change is associated with tardive dyskinesia, which is a form of long-lasting or permanent brain dysfunction. And finally, we also have 6 different studies, randomization studies, where the group treated in a selective manner with neuroleptics did as well or better than the conventionally treated group. And finally, we have the MRI scans showing this enlargement of an area of the brain associated with a worsening of symptoms. So that's, I believe, is an explication of the puzzle of the poor outcome studies that were documented by the World Health Organization. Now, I was doing a radio interview yesterday, Wisconsin Public Radio, and someone came on and said, yeah, you're right, but that's old news. You're beating a dead horse. And in a way, she's right, because away from the public, if you go into meetings with psychiatrists and read their literature, they basically confessed in the early 1990s that these old drugs really had not done at all well in terms of producing any sort of good quality of life, that you had a very poor quality of life with standard neuroleptics. And so we got in the 1990s a new class of drugs called atypical drugs. And they came to market with much fanfare, heralded as much safer and more efficacious than the old drugs. And you also got stories such in the New York Times with a new explication of what was the cause of schizophrenia. The New York Times reported that the cause of schizophrenia now was too much dopamine activity and too much serotonin activity, and these new drugs basically alleviated schizophrenia because they help balance both of these. Well, there is in fact no evidence that schizophrenia is caused by too much serotonin activity. That was just something an explanation that fit the new drugs. What the new drugs do is block both serotonin and dopamine activity. They don't block dopamine activity as profoundly as the old drugs. They don't clamp down on that D2 receptor with nearly the same force, which is a good thing. Patients clearly do not find them as physically painful as the old drugs, and in that way much more tolerable. Now, what I did for this book, though, I was still curious because, of course, if you go through the history of mad medicine, there's always been a cure. I mean, it's been one thing after another that the latest treatment has always been said to be the wonderful breakthrough. It basically has occurred time and time again. And so I wanted to see what was the actual clinical data from the clinical trials that was submitted to the FDA, and how did the FDA, what did it think of these new drugs? And what the FDA concluded in its review was that the trials had been biased by design by the drug companies to make the new drugs look better than the old drugs. Now, that does not mean that the new drugs may not be better than the old drugs. It just meant that the science that was done to test them was basically flawed, and they had basically created a story using trial design to make the new drugs look better. The other thing that was clear from the FDA data was that they were more problematic than the public had been led to believe. So, for example, in the Wall Street Journal, there was a report that there had been basically no severe side effects, adverse events, with risperidone. Well, in fact, if you looked at the clinical data, risperidone is one of the new drugs, by the way, about 1 in 30 patients in those clinical trials suffered a severe adverse event, which meant either life-threatening or needed hospitalization. And you saw this with the other drugs as well. There was complications. There were plenty of adverse events, problematic adverse events. What happened was, though, the side effect profile is different with these new drugs than with the old drugs. That's clear. And on the new drugs, I have no idea whether they're going to lead to better outcomes. They may. I mean, and if so, I think that's absolutely wonderful and terrific and great. My complaint about the science behind the new drugs is, in fact, that the testing wasn't rigorous and wasn't unbiased, and so it's left us in the dark about what the side effects may be and in what way they may be better than the old drugs. There are some good things, I think, happening in the country today around these drugs and around medication use. I think one of the great things we're seeing is, in the old days, with the standard neuroleptics, you basically saw research that was designed to look at, did it diminish the psychotic symptoms? There was very little look at, was it helping people lead good lives? Was it helping them go back to work? Was it helping them have friends? That sort of thing. There does seem to be a new paradigm emerging, new talk emerging, that we need to keep our sights set on recovery. It's not just enough to knock down psychotic symptoms. I think that is tremendous. It's one of the most hopeful things I think that is going right now, and it's really a wonderful development. And in line with that, what you are seeing with some of the new drugs is a use of lower dosages. So, for example, with risperidone, it was tested, I think, at 6 milligrams, 10 milligrams, and 16 milligrams. Well, a lot of psychiatrists are prescribing it at 2 and 3 milligrams a day, and actually they're having, I think, fairly good results at those low dosages. So there is some change, I think, that's happening that is very encouraging. At the same time, having reviewed this history, I am a bit of a skeptic about long-term results that will result from these drugs. And let's take olanzapine, or Zyprexa. It's now the best-selling drug out there. And clearly some patients do find it much more tolerable than the old drugs. And you get some clarity of thought with olanzapine that you did not get with the old drugs as well, so you can see some real benefits. However, you also see some real metabolic problems with olanzapine: weight gain, elevated blood sugar levels, elevated triglyceride levels. You also get an increase in dopamine receptors, which we know are problematic over the long term. If you talk to patients, and there is some of this research as well, you also see incredible withdrawal problems with these new drugs. There's some evidence, in fact, that they're more problematic than the old drugs in terms of the return of psychotic symptoms. And so my belief on the new drugs is we don't know what's going to happen, and I just wish that we would have good, clean, honest science, not biased by pharmaceutical money, to give us the best guidance on how to use them and to use them well. Finally, several reviewers of Mad in America, these are book reviews, etc., have taken me to task for not providing any alternative. They said, well, I've done a critique of the system of care in this country, but I've not offered any sort of suggestion. And that's true. I don't really think it's my place to do so. However, I'll venture that way today. I think here's what if you look at this history, this long history, and what you see in other countries, and this research that's been done in Sweden and Finland and Switzerland, you do see, I think, an example of where we should head, and in terms of what the moral obligation of our society is towards those who descend in a psychotic break. I think you need to have a system, and let me back up, I'm sorry. The thing you see time and time again across these various studies is that at least 40% of people who descend into a schizophrenic break, a psychotic break, if treated with psychosocial care but not immediately placed on neuroleptics, do indeed recover and basically get on with their lives. And I think everybody would agree that a medication-free life, if that's possible, is better than a medicated life. And that's what we saw, for example, in those studies in the 1970s. In each one, more than 50% got well and recovered. So I think you need to have a system, number one, that allows that group of patients who has a chance to descend into who has suffered the misery, the misfortune to descend into a psychotic break and a schizophrenic break. We need to have a system that in some way provides them with psychosocial care and gives them a chance to recover and go on with a medication-free life. So in other words, we need to start having a form of care that, rather than one size fits all, that is more selective. Second, you also see in this history is that a number of patients might have a second episode, a third episode, but then in each time will recover and go back to premorbid status, and over time, frankly, get better over a longer period of recovery. We need to let that group as well have a chance to lead eventually a medication-free life. And the way that can be done is through gradual withdrawal programs. And it's interesting that Harvard medical researchers, when they looked at gradual withdrawal, I think they reported on this in 1998, they found that only 35% of patients relapsed within a 6-month period, and that the remaining 65% did well and had a good chance of remaining well indefinitely. So you see that with gradual withdrawal, as opposed to abrupt withdrawal, you do indeed see success with people getting off the drugs. And then finally, of course, you're going to be left with a core group of maybe 1/3 of those who suffer from a schizophrenic break, who I do believe will benefit from continual medication. Now, in this country, you see nothing of this sort. You see no exploration, no openness to this sort of more subtle, artful form of care. It is completely, we're blind to this possibility, and if you suggest it, you get hammered. People get really angry that you should even suggest this. There is one country that has pursued this sort of more artful form of care. It's Finland. Finland revamped its care starting in around 1980, and here's how they respond. And it's real key you respond to the first schizophrenic break before you start this heavy medication, I believe. They respond with a really comprehensive form of care. What happens is they have counseling, they have vocational rehab, they have counseling for the families as well. And they also involve selective use of antipsychotics. They're finding that some patients do better without drugs, some patients do better with the drugs, and they're actually identifying patient subtypes so they can identify who they think indeed has a chance to recover without drugs and who types that are going to need the drugs fairly soon, I mean, almost from the get-go. And I think if the reform that we should search for is that sort of reform where it's, so I don't believe it's drugs or no drugs. I believe it's what we need is an artful form of care, and that's really what history tells us. That's number one. And the second thing I think we really need to think about is You need to listen to the patients. And if patients are telling you they don't like the drugs, well, there may be a good reason for that, and you need to listen to them. And in the minute you deny them that sort of complaint or that sort of argument, you really are denying their experience as a human being. And somehow in our care, we've got to integrate listening to the patients. Well, I thank you for listening to me, and time for questions. Thank you very much. The people who are televising asked if you do have a question, just to wait, and they'll bring a boom down so they can record that. Gentleman here. So if you have a question, take anything. Start over here. Wait just till the boom comes.
Yes, I want to thank you for what strikes me as a very necessary book, especially given all the bad treatment that's out there. Thank you very much.
Thank you.
I want to make allowance for that I may not have simply heard correctly, but it does strike me, though, that in your developing your critique of psychiatry at this point, all the instances you cited were of treatment for schizophrenia and the medications, the neuroleptics, that are in line, at least in orthodoxy as it stands, for treating that disorder. And I didn't hear a single mention of mood disorders and for the medications that are in line to treat those, namely lithium, carbamazepine, valproic acid, and recently lamotrigine coming on strong. I would simply observe that while I think you have an excellent critique of schizophrenia, that in the absence of any evidence offered on mood disorders, that you can't really legitimately extend your critique to mental illness as a whole. I would be open to that. I just want to know, do you have evidence to make that extension?
Yeah, that's a good question. You know, it's a big topic. It's a huge topic. And of course, I wanted to remain focused on this, you know, the severely mentally ill and, you know, the group that we once called insane, which obviously translates in modern day times into those diagnosed with schizophrenia. I don't know so much about lithium, bipolar illness. I just haven't done much research on it. I have, for various reasons, looked into the antidepressants and you know, for mood disorders. And that's a very fascinating story. It's an incredible story. And real briefly, I'll tell you this. You know, we've basically had two waves with the antidepressants. First were the tricyclics and then the SSRIs. Well, interestingly, first of all, with the tricyclics, the benefit over placebo is very small. It's like 10% or something. Now, and it was so small that in the 1970s, there was a number of studies run in which they compared tricyclics to active placebo. An active placebo is something that will cause a physiological response, like dry mouth. And in 7 of 8 studies, there was no difference between active placebo and the tricyclics. They saw the same improvement, same degree of improvement in patients. That's number one. Number two, the NIMH had a extensive trial of antidepressants, and you may know this, in the 1980s, that had 4 arms, 2 psychotherapy arms, a placebo arm, which was called good clinical management, and a tricyclic. Now, at the end of 6 weeks, there was no difference in the remission of symptoms. In other words, all groups got well, equally well, in these 4 different groups. At the end of 18 months, however, there was a difference. The groups that fared best were the 2 psychotherapy groups in terms of stay-well rates, and placebo and drug-treated did the worst, and they were basically the same, at around 19-20% stay-well rates. And so it wasn't very encouraging for long-term care. Now, what the NIMH did is they went back to that data at that time, and they said, well, we can extract a data pool of those who are severely depressed, that it seems like the drugs indeed have a benefit over placebo. And they basically said, well, there's not a good rationale for the people mildly depressed, but in the severely depressed, you can make a case that the antidepressants indeed provide a benefit beyond placebo that's worthwhile. That's number one. Number two, if you look at the SSRI trial data, one of the things knowing that mild patients respond so well to placebo. And by the way, I need to stop here just for a second. The placebo, there is a placebo effect. It's not just that in these antidepressant trials, the placebo group's doing quite well. And if they didn't believe they were getting a medication, they wouldn't be doing so well. So there is a very positive effect from the placebo effect that's a confounding factor. So you could say from this, what we need is a therapy that kicks in the placebo effect. Just want to make that clear. When the drug companies did the clinical trials for the SSRIs, they deliberately excluded the mild group because they knew it would ruin any evidence of efficacy. So they basically had criteria only for those severely depressed. And actually, psychiatrists from Brown University recently pointed this out. You only have evidence of efficacy for the SSRIs for the severely depressed and not for the mild depressed, who, of course, are, you know, the mass of people being so prescribed. So that's sort of the data, I think, that's out there, the research data. I will tell you, personally, I think SSRIs are a very aggressive form of intervention. They don't balance serotonin. They basically perturb serotonin function. And anytime you use a drug that you chronically administer a drug of this sort, boy, you don't see great long-term results. And it's because, in essence, you are creating sort of an abnormality in neurotransmitter function. The brain tries to compensate for that by going through various adaptations, changing its receptor density, changing its serotonin output. And I'll just give an example with the SSRIs, and it sounds like you're familiar with this. You know that when they gave SSRIs to, quote, healthy people, non-depressed people, you had a lot of suicidal ideation. I forget what percentage, was it 25%? 1 and 4%, okay. But you see, you know, you see problems. And you see, frankly, you see mania sometimes. People can't sleep. These are stimulants. You can obviously psychosis result eventually in some small number of cases from the lack of sleep, et cetera. What happened with this history of psychotropics is we learned how to sort of muck with the neurotransmitters. And of course, that's what we're doing. But that's a profound intervention with how the brain works. And the thing that bugs me is that this, like you see the Zoloft commercial where it looks like they balance the chemicals of the receptors. That's just a lie. That's medical fraud is what that is. And I don't mean to be diminishing that people severely depressed need help. I absolutely believe that. So it's a terrible thing. And maybe SSRIs are good for that group of people. I just think we've sold ourselves a story that these things don't have costs. They do have costs. And whenever you look long-term, you see a lot of problematic costs. And my big worry, and I think maybe you share this, is you do see some evidence of chronic brain dysfunction, low-level brain dysfunction over time. I mean, maybe you can address that, but you do see it. Do you dare to? What's that? You'll defer. Okay. Why don't we go here? Okay, right, there's someone here.
My name is Jiron Onifade. I'm from Nigeria. I'm doing the Night Science Fellowship, Science Journalism Fellowship at MIT. I just want to speak to your reference to an earlier study
the World Health Organization
that cited Nigeria as one of the good cases.
Right.
Maybe so at the time of the study. It's
right, which,
no longer so.
By the way, was 70s and 80s. You're right.
Yeah, it's no longer so, you know, because of the downturn in the economy and urbanization. The social structure that used to support the care for the mentally ill is now absent. People now go about roaming the streets naked until they are knocked down by vehicles or they die of hunger.
Right.
Or you find them abused, you know, with shaven heads, tied together with their clothes, begging for money that will be taken from them by their handlers, money they don't benefit from. And I think what is true of that situation, and I believe is also true of the situation here, is the lack of political ability on the part of the mentally ill. Because of the very nature of their sickness, they are unable to organize themselves, say like people with physical disability would, or people living with HIV/AIDS.
Right.
The way out, which is my critical contribution here, is that some other elements in society must have to take up that political function on their behalf. Since they can't do it for themselves, somebody has to mount pressure on their part, because I've been in the US and I've seen how easily governments at federal, state level, and local easily hit budgets for mental health at the slightest excuse because nobody will complain anyway. So maybe some elements in society will have to take the political angle of the fight for the welfare of the mentally ill. Thank you.
Yeah. I just say real quickly, I mean, I couldn't agree with you more. I mean, of course, here in the 80s, we saw an explosion of homelessness, you know, among the mentally ill, and that was related to withdrawal of social support as well. And, you know, knowing that Nigeria, for example, has had such upheaval in the last 15 years, I don't doubt it at all. What you say is true. And these studies were done in the 70s and 80s, which, as you well know, was a different time. And couldn't agree more. I mean, you need a societal response that begins with providing shelter, food, empathy, all those things you're talking about. How about right here?
Yes. My name is Carolyn Walker, and I've been in mental health. I had my first breakdown at 21. And here in the States, there was a time in the hospital when they were sadistic to patients. And some of the things that you were saying throughout centuries when they were sadistic to the mentally ill sounded very sadistic. But I like what the Quakers did, and I think they should get recognition for it.
Thank you. I mean, I think the Quakers, we certainly can learn a lot of lessons from the Quakers in the early 1800s, absolutely. And you know, the thing that I think is so critical, they always talked about the mentally ill as brethren. They didn't talk them about as people with broken brains. They didn't talk about them as apart from humanity. They talked them as brethren. And I think that, and this even goes to your comments, I mean, that needs to be the guiding philosophy. And I think actually that's one of the problems with always searching for a biological cause. You start separating them out, somehow that they're distinct. They're broken. Well, they're not broken people. They're, you know, people who suffer schizophrenic break are people in distress is what they are. Judy.
I'm really glad that you wrote the book. I'm hoping that it gets the kind of publicity that it deserves. But I did notice in the book and in your talk and to you, it seems like people who've been diagnosed with mental illness are very passive and that they need somebody to come along and do something to them or for them. And you didn't talk at all about, and this goes also to the comment of the fellow from Nigeria, the fact that there are political organizations made up of people who've been diagnosed with mental illness who are trying to bring about change and who are building coalitions with people with physical disabilities and other socially disadvantaged people, and that it's not just a question of waiting for somebody else to come along and take up this banner. Like other groups who've been disadvantaged, we're the ones who are affected, we're the ones who've got to lead the fight.
You know, I agree with this. Judy, by the way, I don't know how many of you know Judy Chamberlain. She's been a leader in this movement for a long time. She wrote a book called On Our Own, which you can still buy. You should buy it. It's a great book. It's back in print. Listen, one of the things that in writing this sort of book is you have to take the argument that's being made by the mainstream, so to speak, and the form of care that's being delivered by the mainstream. I think that what you call the self-empowerment movement, this consumer movement, is a very hopeful thing, a very important thing. You know, they've been on the front lines of fighting for civil rights for a long time, making their voice heard. I regret that your voice isn't constantly heard in the press. We need to hear this voice. Absolutely. It should be, every time we hear a story about, quote, the mentally ill, we should be hearing from groups like yourself. It is a very, very powerful group and important group. And, you know, maybe we shouldn't even address this. One of the issues that's going on right now, of course, is there's really a rollback of civil rights of the mentally ill in this country. You're seeing states pass involuntary outpatient laws, which give basically the state the right to come to your house and forcibly medicate you, which is, you know, that's an incredible impingement on personal freedom in my belief, especially when you don't have a history of care that shows that this leads to good quality of life. You can't even use that as the sort of moral foundation for this forced medication in your homes. And it's groups like Judy's group, and there's a loose coalition, or maybe it's better than a loose coalition of consumer groups across the country that is trying to fight this involuntary outpatient hospitalization. And I think it, frankly, is one of the most important civil rights issues going on today, because when you see an impingement of civil rights, you're really talking about an impingement of civil rights for everybody, I believe. Right behind you. We'll start here and then at Jumi. Okay.
Patricia Keene. I've been in and out of the system in the hospitals for over 10 years now, starting in Met State, and I started taking meds as a freshman in college. And they tried me on medications from Stelazine, Thorazine, Haldol. And it turned before the new drugs came out, the only one that worked for me was Haldol or Thorazine. And now I'm on Seroquel along with L'Occitane for my antipsychotics, and I'm having pretty good luck with it among the other things I'm on.
Well, you know, and I think, again, this goes to the sense that of patient, you know, patient choice and patient sense of what does well for them. So if the drugs are working well, that's great. I mean, I think that's wonderful. And I don't think you want a system of care that says drugs shouldn't be used either. You want, you know, people to, you want the selective form of care. And I don't think anybody should be saying no drugs either.
If it doesn't work, say something.
Yeah, exactly. And you know, there was some studies showing that patients who most resisted the standard neuroleptics were the ones that, in fact, had the best chance of doing well without them, sort of really responding to them. Jumi. Jumi, by the way, I'm going to go ahead and introduce him. Jumi's from Cameroon and has had some experience with how they take care of the mentally ill there.
And I was going to make a comment here. I come from Cameroon, and I'm not from the city, so I come from a little town. And what I notice, I mean, we live with our mentally ill. We don't, they are not sent in the hospital at all. That is one point that I want to make. But secondly, it seems to me that on arrival here, that the sort of people that I see in my town where I grew up who are normal, that they will be probably diagnosed as mentally ill. I say this because I say this also to back it up one point. I've seen a kid who is, this kid really teased my mind. It's really, I thought the kid was very intelligent. And the kid goes in school, somehow the kid was given some drugs, saying that the kid is somehow, I've forgotten how they diagnosed him,
this
attention
is here or
disorder.
in Cameroon?
Yeah, attention disorder. And I find this really, I find this very interesting. And to ask you whether there is a way to more or less look at this sort of cases where you just have normal people who happens to be maybe intelligent or act in a different manner, and somehow maybe they may be conflated as mentally ill. Is there a way to somehow to distinguish this sort of people?
Well, you know, that's a great question.
Again, with respect to this sort of kid that I mean, the sample may be small, but I think a lot of people can testify that you have these kids who more or less, as I said, they tease the mind,
right.
You know, and I just thought this was a wonderful kid.
Right.
And somehow the teachers thought that the kid is out of his mind. You know?
Well,
I mean, in my home, the kid will be embraced as a sort of wonderful kid. It will never occur to anybody to think that this kid was abnormal.
Well, you know, that's one of the, you know, there's diagnosis is, you know, that's a whole nother story, which I do address in the book. I mean, the diagnosis of schizophrenia in the U.S. became so liberal in the 1970s, 1960s, they were diagnosing everybody with schizophrenia. I mean, I'm being facetious here, but it became a very loose diagnosis, so much so that when people looked at it, they estimated in some instances that like 4 out of 5 people so diagnosed really shouldn't have been so diagnosed. And that's number one. Number two, there is clearly, sort of a racial and class element in the diagnosis of schizophrenia. African Americans are much more likely to be diagnosed with schizophrenia than white Americans. Lower class as well are more frequently diagnosed with schizophrenia. So there is that element in it, and that's been found time and time again. And now what you're talking about, sort of the medicating of kids, well, that's a whole nother story, but clearly we in the United States are defining ever larger groups of behaviors as pathological and in need of medication. And I think it's out of control, but that's a little bit away from this. I mean, there's no other country in the world that's medicating its kids like we are to the same degree. I mean, it's amazing. And one small thing, Ritalin, by the way, if you want to know what it does to the brain, it acts on the brain in the exact same way that cocaine does. The only difference is how fast it gets into the brain. But it ups dopamine levels in the exact same mechanism that cocaine does. Probably not going to see the Ritalin advertisers say that. Right here and then over there.
Hi, my name is Amanda Jones. I work for an organization called the Massachusetts Consumer Satisfaction Team, and we're a group of primarily people with mental illnesses and family members of people with mental illnesses who go into hospitals and do a lot of what you're suggesting, talk to the patients or the consumers or clients about what they like and don't like about the services they're getting and the medications they're on. So I applaud a lot of what you're saying about looking into what the people with mental illnesses actually need and want. However, my question is a little bit more on the critical side.
Sure.
I have to confess, I haven't read your book yet. So if this is in your book, I apologize. But I know it's right on the front, the jacket cover, and I've heard you on NPR and other places talk about the World Health Organization study.
Right.
And immediately what pops to mind for me is this comparison between developing countries and more developed countries. Was there any matching between the people who were being medicated or treated in the developing countries versus the developed countries? In other words, sure. I mean, are we talking about similar groups
apples
of people?
Apples. Right.
Or are we talking about people who've had different lengths or different amounts of time since the initial onset of their illness and different severity of symptoms?
Right.
I would just think, since we've been talking so much about cultural differences
right.
and stuff, that would play such a large factor that it would make it very hard to compare.
Right.
And I just know that a lot of your critique starts out
right.
talking about that study, and I'm just wondering about kind of the legitimacy of that
No,
study.
no, that's a great question. And trust me, I've heard a lot more critical stuff. That was, after they did the first study, that was exactly the criticism that was raised by basically Western doctors who were embarrassed by this outcome, clearly. I mean, you know, they said, oh, you're talking about some other diagnosis there. You've misdiagnosed the people. And so that must be it. They're ill with something else, maybe a viral illness or something like that. And so that's actually why they mounted the second comparative study, was to answer that criticism. So what they did in the second study is they only looked at first episode patients, okay, newly psychotic. It was Western doctors doing the diagnosis, okay. It was WHO doctors. They even, so they had that control. They even divided the groups up by different subtypes, you know, with presenting symptoms. And they divided outcomes by subtypes. And what they found is it didn't matter. Across different subtypes, you also saw this better outcomes among in the developing countries. So they answered that criticism. And again, it was Western doctors doing the diagnosis. But it's an obvious point to challenge.
I'm Dan Kriegman. I'm working with a group that inspired by Lauren Mosier and Judy Chamberlain, and is trying to create the kinds of places that don't exist in the United States. In fact, we're having a fundraising benefit concert next month, so I'll have literature back there to let people know about it, so people can have a home, a house that's theirs, run by them, without having to have medication compliance or other institutional rules where the consumer, the people who live there, establish the rules, and we're trying to raise money to establish this house. And I'd like to say to you, thank you for the work you're doing. I also have a question.
Sure.
I missed the first 5 minutes of your talk, so I don't know if you mentioned this, but your article in the USA Today about the movie A Beautiful Mind, and, and with the placement of drug ad information or misleading information into movies, with the ridiculous commercials on television now, on mainstream broadcast TV, where, you know, anxious, maybe you've got a chemical imbalance. Depressed, well, of course you've got to take a medication. And it's like the mindset is so thoroughly entrenched. You know, biological, human experience is now thoroughly, it's conclusive now with the, you know, the Genome Project. It's a, you know, genetic, biological experience, and that's the way to go. And with all the money, I'm just terrified. What's your response to that sense of all the money of the pharmaceutical companies behind all that? Do we have a chance?
Sure. And you've actually raised three things, and maybe I can address all of them. To your latter point, yeah, I think what's going on in the country with this view of ourselves as sort of determined by our chemistry is a really frightening development, because it does end up with sort of a deterministic view of humanity, that we're determined by our brain chemistry, and it doesn't leave a lot of room for free will. There's also something that sense that, well, we're all supposed to be happy, aren't we? We're not supposed to be anxious. We're not supposed to be sad. We're not supposed to be depressed. Well, frankly, that's what being alive often is. I mean, you do feel anxiety. You feel depression. Frankly, I felt a lot of anxiety at about 5:30 tonight. Didn't take a pill. And I think we're missing the sense of the spectrum of humanity, what it is like to be alive. I mean, where this idea came that you're supposed to be happy all the time, it's ridiculous. And, you know, one of the things that you see, for example, I think is just unbelievable, was that in the wake of September 11th, you saw drug companies seeking to capitalize on this sort of free-floating anxiety and saying this pill will make you better. Think of that as a national response. Rather than coming to grips with what was going on, we can take a pill to somehow make it all go away. I think that is, sorry, I was going to say insane, but you know what I mean. I think it's just, it's an outrage, and I think it's harming us as a people to think that. And clearly, you know, you can go with the kids and Ritalin, a greater group of kids somehow need that medication. So that's that question. The first question that you mentioned was Lauren Mosher, and I'll just expand on this real briefly. Lauren Mosher was head of schizophrenia studies in the 1970s. He set up this experimental house. It was one of the experiments I mentioned, called Soteria House. And the idea was that you would go there, and frankly, there was no really professionals in the house. They would just get people who showed a lot of empathy for people, who weren't frightened of people who might be going through extreme distress and behaving in disturbing ways, and that he wanted to see, could this be a healing environment? Well, in fact, he found that it was a healing environment for a great number of people, but he lost his job. He was kicked out of NIMH, in essence, because of this experiment. And the reason he was is because it went against the prevailing sort of monetary influences that related to the selling of drugs. So if you're starting such a house, all I can say is God bless, because it's the sort of exploration of alternatives that I think is so necessary and can be so welcoming. By the way, do you know the Birch House by any chance? Weren't they doing something like that in Vermont? New Hampshire. But I think it got shut down, right? It's close. It got close. Ran out of money. Which, you know, and I think at the very least we need these sort of alternatives, and for those who want that sort of alternative. And also, I would like to see some sort of science done when you get this house open to see how patients fare in it. The final thing you raised the question was about the movie A Beautiful Mind. Now, what happened with the movie, those of you who've seen it, just before he gets his Nobel Prize, he talks about, oh, I'm on the newer medications, with the implication being it's the newer medications that's helped him get well and helped him keep well. We're talking about John Nash, the Nobel economist. The problem was that in truth, John Nash hated the drugs, stopped taking the drugs in 1970, and slowly recovered thereafter. So you have this incredible fib that was done basically to support the prevailing wisdom about the merits of these drugs. And I may get in trouble with this. National Alliance for Mentally Ill even put out a press release praising the film for showing the vital role of recovery in John Nash's case. Now, I'm not saying that you just don't want to fib in that way. This is just one individual man. Just let his story be as it is. And an anecdote never tells you, it's not a referendum on drugs either way. It's just one individual response, and so you should be true to that response, I believe. Right in front.
30 years ago, in this state, our governor discovered that there were hideous conditions in large mental hospitals and decided that he would close them and open supposedly halfway houses, and these people would have an opportunity to live in the community and transition to the community, etc. Of course, many of those halfway houses did not happen, and partly as a result, I'm supposing, there are a great many deeply disturbed people living on the street, and liberal politicians say something like the rich as well as the poor and the sane as well as the insane have the right to sleep under the bridges. And I'm not proud of that, and I don't enjoy stepping over people sleeping on the grates in my city. What does Finland, for example, do about people that don't want to be treated but definitely need help?
Unfortunately, I don't know Finland's story that well.
I cite Finland because you cited Finland.
I just know that for example, Finland is reporting that over half of its patients who descend into a schizophrenic episode, get diagnosed, are holding jobs 5 years out and not having psychotic symptoms, because you do have this sort of societal-wide response. I think there's a little bit of blaming the mentally ill here, in the sense, I'm not talking about you, but I mean us as a society for the homelessness, saying, well, they don't want their medications and they don't want to be treated. What really happened, the reason we got this explosion in homelessness in the 1980s was the result of a social policy. It wasn't that liberal politicians went forth and said they have the right to forego treatment and live on the streets. That really wasn't what was going on. All that you had was, the liberal, I guess you would say, saying the right to forego treatment, forced medication. The reason we got the explosion of homelessness was this. Deinstitutionalization worked in this way. In 1965, of course, we passed Medicare and Medicaid. And what Medicare and Medicaid did, it allowed for the transfer of expenses from the state to the federal level. So instead of the states paying for mental hospitals, now the feds would pick up that money. And so what happened is patients got basically released from the nursing homes, from the state hospitals into the nursing homes. That was the first step in deinstitutionalization. A second step that really speeded this up was the 1973 Act, the Social Security Disability Act, because now this group of people could get Social Security disability payments, welfare payments, and that could go to boarding homes as well. And we got the explosion in the 1980s, early 1980s under Ronald Reagan, and the reason we did is because Ronald Reagan wanted to cut welfare rolls, and he put in a policy saying that they would have to reestablish, everybody on these rolls, reestablish their eligibility. I forget what the time period was, every year, every 2 years, and of course it was this group that was least able to reestablish their eligibility, and next thing you know, their welfare payments were cut off and they're out on the street. And as you said, we never built the homes either. We never built good shelters, so we never committed, or we never fulfilled the promise we made when we were going to shut down the state hospitals to provide good shelters, caring shelters. So that's just a social policy that failed at every turn. And as the gentleman here said, it shows a lack of societal response. And maybe for the gentleman behind you, what you sometimes hear in the consumer groups is, why should they're tired of waiting for a societal response, and they need to take it into their own hands. Because clearly, and what's going on with the budget cuts now? I heard the other day there's going to be a $2 billion shortfall in Massachusetts in the next budget, something like that. How much is it? Is it $2 billion? Something like that. And so you can be sure that mental health services are going to be cut. They're already being cut. It's the first sort of thing targeted. So we're going away from any sort of comprehensive commitment. And this is the amazing thing about the history. Here you have in the early 1800s a poor society really making a real commitment to provide, sort of real good shelter. And they would even bring in speakers to these asylums, educated speakers. In fact, sometimes the entertainment at some of the early asylums in the 1820s, 1830s was seen as the best entertainment around in terms of academic speeches and all. They had libraries, and this was 200 years ago. I hope I answered your question. Behind you? Can you wait for the boom just for a second? Oh, sure. Didn't recognize you, Nicholas.
My name is Nicholas Holohan. I work for the Department of Social Services. I wanted to comment and expand a little bit on your comments regarding children. I am going to take a little creative license, but say that it is getting fairly close to the point where you can welcome a third grader into the classroom by, here's your desk, here's your pill of Ritalin. It's getting very close to that to a scary degree. The other point that's even more scary to me, though, is the fact that you were commenting on the rollback of civil rights. Children have even less ability to put input and have input into what sort of medication they have and are provided with. And I work primarily with adolescents, and I see kids who have been on drugs already for 10, 12 years. And by the time they're an adolescent, you give any adolescent something and say, here, it's good for you. They're going to say, screw you very much, I want a joint instead. So they are going off their meds, which may or may not have been helpful in the first place, but regardless, they're going to reject that. I see that as, that's my first comment, as a real crisis. My other point is that if we were going to manage this more appropriately, if we were going to put in particular for children, more in-home supportive services, you touched on the budget crunch. It's not going to happen because no one is going to be willing, and particularly during a congressional and governor running year, to say, oh, we're going to be spending millions more on the mentally ill. It's not going to happen. But no one is telling the drug companies, no one is telling the HMOs, you've got to tighten your belts and you've got to come up with in-home supportive services. What is being told to them is business as usual.
I think that medicating of children, going on what you're saying, is just, it's a tragedy. I really believe that. Steve Hyman, it was up until recently the director of the National Institute of Mental Health, and he published a very interesting paper about 5 years ago. And what he talks about on all these drugs, you end up with perturbations in normal function, such that by the end, such as on Ritalin, you end up with a brain, and this is, I think I'm pretty much accurate, that is functioning in a manner that is qualitatively and quantitatively different from the normal brain. So should you be doing this to children who can't consent, 10 years of Ritalin? I mean, I think that's really tragic. And for example, there's one study on Ritalin about, what was it? They said they had an incidence of psychosis related to Ritalin, something like 9% in one study. Another study said about 25% of the kids started having evidence of emotional flattening. And you're right, they're not consenting to this. They're not saying, I want to be on Ritalin. I mean, the expansion is incredible. And as far as the money forces, one of the problems, what we have going on is we're spending so much on prescription drugs, when every new drug is always said to be so much better than the old drug, and of course we don't really know that's actually one of the things that's spiraling out of control now with healthcare costs, the costly prescription drugs, and we don't really know if they're any better than the old drugs. And of course we're expanding who needs to be on the drugs. And then what happens? We don't have sort of social services for the children that need them. I think the thing that's so outrageous is we're a rich country. I mean, we're the richest country around, and we can't provide social services. I find that outrageous. Hi,
I'm Cassie Quinlan, and I've worked in, been involved with substance abuse, self-help kind of treatments, and it just, I certainly the concept of using the word brethren is so important. and the notion that we've become estranged. I mean, when you think of the prevailing sort of mentality, it's not only the drug companies, it's sort of the hugeness of the organizations between media, hospitals, and one of the things that strikes me about sort of treatment of mentally ill is how it's defined medically by the symptoms. When in actual fact, I mean, you've got I don't know, the young people going into adolescence, other young people going into the workforce for the first time. There are major life transitions that are difficult for everybody to go through. It's not the same for everybody. It seems like people, even in science or even in the explanations, they're looking for a one-size-fits-all explanation to pass around for once and for all or something. But in actual fact, it's millions of small cells of things, and I think that sometimes it's even just the treatment, the notion of professional treatment in itself, while in some ways very helpful, the limits of it are just not known. And to have more things like 24-hour hotlines for various crises, just for calling for different things, for things like, I was just reading about it, where they were teaching. They had autistic students, and they had peer students teaching them social skills. And the autistic students would respond to the peers teaching them. Where they, so that's just a whole dimension of life that's so rich.
I think what you're talking about is we all respond to the same things in terms of kindness, empathy, friendship. All these things are so necessary. And the way we treat in this country or talk about it, we do talk about symptoms. You have this symptom out here as if it's apart from the rest of your mind. And I think we are losing the thought that to be alive is to grapple with your mind and to grapple with your thoughts and to grapple with your emotions, and certainly to be 7, 10, 18, 22 is, those are transforming times. And just one quickly thing, I was on Wisconsin Public Radio, yes, I mentioned earlier, and I mentioned that, these sort of humane treatment could be healing. And someone came on and said, "Are you actually suggesting that kindness and friendship can help people?" I said, "Yes, I am. I'm going to be bold here." So it shows how far we've gone down this road. Right there?
This actually follows up on that comment. When I'm curious on when you say people react angrily to your book. What kind of anger are they expressing, and what is motivating that?
Well, it's been on a connection. I had a doctor who was quite angry with me. I mean, it's really from people who, are psychiatrists and believe very much in the biological psychiatry model, and they find this critique threatening. I mean, there was a review in Barron's financial newsletter that recently appeared that the publicist at Perseus is afraid to show to anybody because it's so nasty. I mean, it's like filled with, this is a propaganda masquerading as fact, that sort of thing. It's threatening to a lot of things. It's threatening to a paradigm. It's threatening to what we believe. So we've come to believe this is how we see humans now. And it's threatening to a lot of monetary interests as well. I mean, olanzapine is a $3 billion a year drug. Do you think that we're going to do any studies to find out what the long-term negative effects of olanzapine are? Forget it. It's not going to happen. So, there's a lot of money that when you do this sort of history that shows their own research doesn't really add up, people get angry. Okay, 2 more quick questions. How about Ken and then here? Ken? Just a second, waiting.
This is, I guess, this is more of a comment than a question. I mean, this book is a great book, and everyone should buy it and read it. It's one of the really important contributions to the history and critique of psychiatry. But one thing that's been a little disappointing, a little bit in the book, and also today in our discourse. I mean, for 40 years now, this critique of psychiatry has been very well developed, and essentially what we're basically hearing today is the same old discourse, the same language, use of the terms illness, mental illness, schizophrenia. This whole medicalization of essentially psychological problems has been thoroughly debunked now for 40 years. And it does trouble me a bit that somehow we still find ourselves using this discourse. I mean, the whole notion of the concept of schizophrenia has been completely debunked. It's a word that should never be used. People break down and suffer and are overwhelmed and feel powerless and oppressed and react in all kinds of ways that are extremely disturbing to themselves and others, but that's not illness. However, we've been almost forced by psychiatry, feeding at the trough of the drug companies, to use these kind of concepts and use this language rather than understanding these increasing problems that we're all having in psychological and social and political terms.
Mm-hmm. Well, I mean, I think language is, language does define thinking in many ways. Two things. If you have sort of a mainstream story out there, you almost have to use the language of that mainstream story to basically even raise questions, I think. So there is that limitation as you come upon this. In terms of, the diagnosis of schizophrenia, I mean, the irony here, somewhat what you're saying, is that even the believers in the biological model will say that really we should be talking about, quote, group of schizophrenias, that there's no discrete schizophrenia, and really there's, sort of different types. So, I mean, even from the believers, and in fact, Nancy Andreessen, who's the editor of the American Journal of Psychiatry, sort of confessed a couple of years ago, I wish someone would we wish we could figure out who really has schizophrenia or what it is. So, and this is from a mainstream broken brain person. So we're always hearing that we know that schizophrenia is this, schizophrenia is that, and it really is a term used to describe symptoms of, varying types, actually. But, language is tough. It is a tough thing to talk about, I agree. Last question over here. Wait just for the boom.
Hi, my name is Karsten Kuchmender. I'm a first-year doctor, just graduated from medical school last year. And, well, first of all, thank you for raising the attention to the needs of the mentally ill. So I was reading your book, and during medical school I've been very interested in neuroscience and still am. Mm-hmm. I was wondering, reading your book on the one hand, hearing the discussion tonight, which seemed to focus more on the society issues around how mentally ill people are treated. You gave the example of Finland, where a comprehensive psychosocial treatment that is paid for by society is really helping people. There are, on the one hand, these facts, and on the other hand, as I was reading the final chapters of your book, it seemed very much like saying how bad psychiatrists and scientists are and how they are doing bad science. And there may be problems there, although on the other hand, just to give one example, you cite Martin Keller as a psychiatrist who receives an enormous amount of grants, and the New England Journal of Medicine would have had difficulties in finding somebody who could write an editorial.
You're talking about the antidepressants.
Yes, yes. And I mean, the study that he published was that psychotherapy and antidepressants are more effective than either of it alone, which is a pretty benign finding just by itself, and not like for the pharmaceutical industry. So my question is, why is the subtitle of your book starting with bad science, bad medicine, and why don't you raise a little bit more attention for the society effects, which seem to be, from my point of view, the major problem?
That's a great question. I guess the answer to that is this. It's just that there's a widespread recognition, I think, in the country that our social care has fallen down of the mentally ill, and has for some time. The question is then, and that's sort of accepted, so the common wisdom is that our medical care is good, our social care is bad. And if you can write that story, you'll be applauded by, the mainstream psychiatry. The reason is, but the question is then, and go back to the WHO studies, it wasn't just the U.S. that had the poor outcomes. It was other countries with incredible social support system that had the bad outcomes as well. And why was that? Say, England, Japan, Czechoslovakia. And frankly, I think that you really do have to focus in on the medicine, at least as it was under the old drugs, because you do see that the medical model itself produce this chronicity and produce this change in, basically the supersensitivity to psychosis. And frankly, that becomes a real biological problem that you have to confront. Now, the title for Bad Science, Bad Medicine is because, and by the way, I didn't really want to condemn psychiatry as a whole. By the way, I think a good psychiatrist, a good therapeutic relationship, boy, there's plenty of people who tell you that's a very healthy, healing relationship. It can be a wonderful relationship. Now, do we have a society set up today to further that relationship? No. Really, psychiatrists are paid to prescribe pills today. The reason for Bad Science, Bad Medicine is because when we saw studies, for example, which did have better outcomes with this sort of non-drug or selective care, well, the moral responsibility at that point is to explore that alternative. That is the scientific responsibility. That's number one. Number two, if you have a scientific finding, for example, that you hypothesize that too many dopamine receptors lends itself to psychosis, and if you find in science that they don't have this abnormality before they're medicated, and they do have it after medicated, that is our obligation to respond to that from a scientific point of view. What did we do? We just kept on lying. We just kept on saying they had too much, you can read about it for year after year, too much dopamine overactivity. That's the bad science and the bad medicine because we didn't explore the scientific findings. And that's what good science is. And bad science with the new drug trials. You don't bias studies, and we got to get out. We don't bias studies to make the new drugs look better than old drugs. That's bad science. And actually, here's the thing is, I'm a believer in science. I love science. I love the scientific approach. And actually, one of the things I feel betrayed by is, in fact, that you don't see that here. You don't see this willingness to go where your own findings are taking you. And so when Lauren Mosher finds better outcomes with Soteria House, don't we have a moral obligation, even from a scientific point of view, to further that experiment? I would argue we do, and yet we didn't. We just shut it down. So that's the reason for that title. We need to call it. Thanks very much. Sorry, ran so long.
That's cool. Thank you very much. And Bob will be upstairs signing books right now.
Robert Whitaker is author of Mad in America, Bad Science, Bad Medicine, and the Enduring Mistreatment of the Mentally Ill.